The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and Flightbridge Ed in their entirety. This is the Flightbridge Ed Podcast, critical care and emergency medicine education for nurses and paramedics.
Everybody, Eric back with you. It has been a minute since I've been back on the podcast. Been super busy with content creation, travel, and school. So excited to have Dr. Lauria back on the podcast. We're going to do kind of a tag team approach to looking at respiratory failure in the obese population, right? The obese patient, and really looking at these patients with multiple different disease processes in play. How's it going, buddy?
Good. Doing great, man.
Well, we have a couple of great cases to kind of highlight, and I think that this is, there's going to be some enlightening pieces. I know I learned a lot talking to Mike about the case that I'm going to present, and just really gave me a much broader perspective, and I definitely think this is going to help each one of you out there taking care of patients. So we'll start off with our first case. Our first case is a 42-year-old female patient that comes in, has a pretty significant history of COPD. COPD disease is pretty progressive, comes in with some COPD failure that is then diagnosed with pneumonia, and she quickly goes downhill and is diagnosed with sepsis that progresses into ARDS. Multiple flight crews are called to this hospital over a few days to try to transport this patient, and they have a very hard time trying to transition over to their ventilator, ultimately to where the patient did not get transferred. A third flight team comes in eventually and has the same difficulties moving the patient over from the hospital ventilator to the transport ventilator. They are using Hamilton T1, and really few pieces of the puzzle here. Number one is the COPD disease was pretty progressive. And so the crew initially was struggling with the decision of setting that inspiratory pressure. The inspiratory pressure was set to protect the lung because the diagnosis based on the physician, the radiologist, etc., was ARDS secondary to sepsis and respiratory failure. And so they were trying to keep that inspiratory pressure low, but they were not able to generate a tidal volume based on this patient's size. This patient was about 170 kilos, morbidly obese. And it wasn't until they got on with online medical, they made some corrections, sat the patient up, and increased the inspiratory pressure to pressures that really do exceed what we would say for the standard lung injury patient, right? We're always focusing on trying to keep a plateau pressure less than 30, a driving pressure less than 15. And so this was really counterintuitive to them. They were a fairly new flight team to critical care. I think they did an outstanding job troubleshooting the problems, but it definitely was difficult for a while to ultimately make the decision, along with medical direction, to raise that pressure up. And once they did that, they increased the PEEP to 15. They started generating enough tidal volume. SpO2s started to climb, and they brought SpO2s up to that 91, 92%. So that really is the big picture of this case. And this is where I got on the phone with Mike. We talked about this. We've been planning on doing this podcast for quite a few months, both of us busy. And so this is where I'm going to kind of let him take over and talk about the different nuances of this patient and the overall decision-making.
Yes, this is a very, very interesting case. And I think something we run into not infrequently, as we're seeing lots of patients that are obese, morbidly obese, super obese. I mean, our crews around the country are transporting some pretty large people. And it's an interesting question, right? Because you have multiple sort of pathologies that are superimposed. You have the underlying obesity. You have what is at least diagnosed by the sending facility as ARDS and this underlying issue of COPD. So what I would like to do is I just want to back up and define a couple things, talk about some important underlying physiological issues with morbidly obese patients, and then go into like the actual management of the respiratory distress. Getting on the same page is really important with these patients because understanding that we see a lot of obese patients, and generally speaking, I think we see so many obese patients these days that like we're like, oh, BMI like 31, 32, like it doesn't even like bother us anymore. That's a lot of our patients. But once you get upward of 40, that's morbidly obese. And even the surgical literature and the critical care literature discusses super obese patients. So a BMI greater than 50, which is very large. And essentially, the all-cause mortality for these patients is super high. They have lots of complications, usually multiple underlying medical problems. So it's not surprising that we're going to see them in emergency departments and be flying them or moving them by ground to other centers. So we're definitely going to see these patients. All right, let's talk about some of the physiologic changes to the respiratory system. So I think if you understand the physiology, and this is where it gets really, really cool, you can better adapt to both the non-invasive and invasive ventilatory parameters. So starting out with the underlying problem here is essentially a restrictive pathology, right? There's lots of person that's pressing down on the lungs. And so what you get is it's not necessarily an issue exhaling, but it is for like an intrinsic lung problem exhaling, but rather it is generally an issue with them taking big enough breaths and exhaling that becomes the ventilatory component, right? Their functional residual capacity is reduced in some cases by almost a third of otherwise of age matched and height matched patients. So that's pretty significant. So just like when their diaphragm is at rest, they have lower volumes in their lungs. They also, interestingly enough, in some studies have pretty significant airway issues. So all of that tissue, adipose tissue and fat tissue around their neck and upper torso, if you actually do CT scans, a lot of these patients, their airways are significantly narrower. So that makes things even harder. But getting back to the functional residual capacity problem, right? If at rest, all that tissue is pushing and crunching your lungs, and the belly fat and the visceral organs are pushing up on your diaphragm, and you have compressed lung tissue that's not getting aerated, but blood is running past it, you have an intrinsic shunt. So a lot of these patients have hypoxemia at baseline or issues oxygenating. And overall, because of all these problems, right, the difficulty oxygenating because of the stuff we talked about, the difficulty ventilating because you have to do a lot of work to move all of that tissue through what is often a slightly smaller airway. And remember, small changes in airway result in significant changes in resistance to flow through those airways. All of this contributes to a lot of problems with respiratory disease, and at baseline, a lot of problems compensating if they get sick. So they don't have a lot of compensatory reserve. So all these things set them up for badness to begin with.
So, with this case, I think one of the things I remember while being on the phone with this crew with the medical director was they saw an immediate improvement when we really sat the patient up. And I think that's something that is a simple concept that I can forget. We all could forget that sometimes even 20, 30 degrees we think is enough, but man, sometimes you got to crank that bed up.
Yes.
And how much lung recruitment we gain by doing that simple maneuver.
Yeah, exactly. With these patients, when they're in respiratory distress, I think that's one of the very first things I think about because it's easy, it's quick, and it's very helpful. Now, it's interesting though, because with these patients, there's like a happy spot, right? Laying flat, they do not do well. All of the like abdominal, the pressure from the abdominal viscera and all that belly fat pushing up underneath their rib cage and squishing their lungs and like pushing the air out is a problem. So sitting them up is good, right? And actually, what we looked at a couple times is they always have those classic pictures of like those ramped patients and all like the airway books and all the text like intubating obese patients and whatnot. I don't know where those people worked. I can't find, if I'm in the emergency department and I find a blanket or a pillow, like I'm lucky. I don't know what ambulance is carrying approximately 92 blankets to ramp somebody up. But we certainly don't have that in flight. So actually what we looked at was basically just using the Stryker cot or the Rofu or whatever stretcher you're using, and just by lifting it up a little bit and almost putting padding or a pillow under their head at the very tip of it and getting them in a slightly better sniffing position can be helpful. So you just got to be careful if they have any neck problems or acute trauma, their neck going back over the edge of the stretcher or near the edge of the stretcher. I'm not saying dangle their head off the back of the stretcher, but positioning them can be really good. Now, the interesting thing is if you sit them up too much, you go back the other way. Because if you sit them straight up, like in a chair, you're pushing their rib cage over their belly, and it's like us hugging a beach ball and trying to do a crunch on it. That also like pushes up on their lungs. So there's usually this happy spot, and usually it's between like 30 and 50-ish degrees, somewhere in there. But sometimes you just got to play with it a little bit. But getting them up, definitely not flat, is important. So I think it's also important to talk about the pressures, because this gets at one of the issues the crew was having. And I'll wind back a little bit just to say a lot of these patients will do okay with non-invasive positive pressure. But the concept here, whether you're mechanically ventilating them or using non-invasive pressure, positive pressure ventilation, is the same. And that is, and I will often start out by thinking about it in sort of in 3 steps. And actually, the most important step to me is making sure that we have adequate PEEP, EPAP, CPAP, that expiratory pressure is high enough. And that's really important, because essentially what you're trying to do is help this person maintain their functional residual capacity, help them maintain as full lungs as possible against all the pressure of the chest wall, the adipose tissue, and the fat. And this gets into like probably one of the most important concepts with these patients is this idea of the transpulmonary pressure, right? So when let's say, for example, this patient they had who was mechanically ventilated, and you take and you hit the inspiratory hold. Let's say you have a ventilator that can do an inspiratory hold, or you're still on the setting facilities ventilator that can do an inspiratory hold, and that shuts a valve, and you actually measure the static pressure in their lungs, the plateau pressure, right? Which we always do. We document it. We can calculate it off the Hamilton, but it doesn't measure it directly. That number is a measure of the respiratory system compliance. And when I say the respiratory system, think about this, right? You have all that air in the lungs, and you shut that valve, and it's measuring the pressure pushing up against that valve, right? Okay. All of the stuff pushing on that valve is the lungs themselves, the chest wall, the bones, the muscles, and everything on top of it, which means everything pushing on the lungs. So it's measuring the pressure of the guts pushing up on the lungs. It's measuring the pressure of all of the adipose tissue and skin and everything pushing down on the lungs. What we're really worried about, why we're concerned about that plateau pressure, is we know that it is, or at least we believe, we have pretty good evidence that that when we measure a plateau pressure, if we are generating a static pressure against the lungs at the end of expiration that is higher than 30, right? That number, then at least in ARDS, that is associated with worse outcomes, right? Lung injury and ventilator-induced lung injury. However, that is predicated on the understanding that that is the stretch or push or pressure that the individual alveoli and the lung parenchyma is experiencing. For a numbers problem, I'm going to throw some numbers out there to just do this little thought experiment. So let's say your plateau pressure is 30, And that is measuring all the pressure of the skin, the fat, the muscle, the bones, and the lung pushing against the air, which pushes back on the ventilator. Let's say you're a relatively thin, healthy, athletic person, and the sum total of your chest wall and all of your fat, because you're a relatively like healthy, skinny person, is only about, 5 centimeters of water. And let's say you remeasure the plateau pressure and it's 35. 5 of that is from the chest wall and the muscle and tissue and stuff. And you're like, okay, whatever. The lungs are the other 30 centimeters of water, roughly. It is these stiff, inelastic, inflamed lungs that you are pushing against with, if you want to think about it that way, with 30 centimeters of water. Now let's take another patient. That same patient, same height, same ideal body weight, only this time that patient is super obese. So that patient has, we'll just say for hypothetically, right, 15 centimeters of water pressure equivalent, probably more, right, if you're super obese, pressing down on the chest wall. When you measure 35 centimeters of water, 15 of that is from the chest wall, the fat, all that other stuff, right? Which means only 20 of that is what the lungs are really seeing, stretching them out, pushing against them, which is interestingly enough, relatively safe, right?
Absolutely.
So even though the plateau pressure is high, with this super obese person, a lot of that pressure is work against holding open the chest wall and all the tissue. And it's not necessarily the lungs being stretched, pushed, pressure against the alveoli in an injurious way, if that makes sense.
It makes total sense. Definitely something that we've always taught, that your plateau pressures can be increased for, the weight of the chest, abdominal compartment syndrome, things like that, obstetrics, pregnancy, and I think when you get into the meat and potatoes of a patient and a patient care encounter, it's easy to forget that stuff. You just look at a number and you're like, man, I've got a plateau pressure of 35. I've got to get that down. You don't look at the big picture of, at least I can admit I haven't. So I think this is huge. Can you talk really quick or at some point about the relation and surrogate number of driving pressure as it relates to decision making in this patient?
So this brings up a really good point, and where driving pressure may be helpful or instructional, right? So let's say you have a patient who's not oxygenating well, and you have them on 15 of PEEP, and their plateau pressure is 30. So their driving pressure is also 15. In this case, it may be reasonable to go above a plateau pressure of 30 if the driving pressure remains 15, because if the driving pressure is staying at 15 and you go up on the PEEP to 16 or 17 or 18, that patient may need that pressure to recruit good lung. But as long as their driving pressure is staying at least at 15, that's probably reasonable. Again, the driving pressure, because it starts out with the plateau pressure, doesn't always take into account all of the adipose tissue and the pressure of the chest wall and whatnot. But this would be a really great place where, as long as that driving pressure is 15, if you need to go up on the PEEP more to oxygenate them, especially in the setting of like a super obese or morbidly obese patient, that may be very reasonable.
This patient with the COPD pathophysiology, the history, and then the obesity, she's going to need a greater pressure to open those airways, right? And driving pressure,
yep.
The definition is, what is that critical airway opening pressure?
That's actually a really good way to look at it. I also think it's important to put it in perspective for everybody, because we're so used to seeing a lot of patients, and in general, you walk into an ICU and the PEEP is like 8, 10, 12, whatever. If you look at coming from the pulmonary clinic, some of these patients with obesity hypoventilation syndrome and OSA, but in particular OHS, obesity hypoventilation syndrome, it is not uncommon for the pulmonologist to titrate their home CPAP to 20s over high teens. So that's someone who's just going home and sleeping at night, but requires like 26 over 18 as like their CPAP and BiPAP settings at home. I am not recommending, to be clear, I'm not recommending that people start there or titrate up there for all patients. That's probably not okay. But you should just to like calibrate your brain to think about the kind of pressures that some of these patients need just for healthy lungs on a regular basis to manage them. For these cases, I would strongly encourage people to work with their clinical leadership or their medical director and consider putting in into their clinical guidelines exceptions or guidance for some of these patients that are obese, morbidly obese, or super obese, to provide some better guidelines for liberalizing some of those pressures. That's okay with the medical director in your receiving ICU or whatever. At the very least, it should prompt a discussion with the receiving intensivist or the receiving doctor or your medical director or medical control to discuss this, because it's probably a good idea in these patients. In fact, it's recommended and beneficial.
What advice do you give to the masses out there, right? We have listeners all over the world, different medical direction, different guidelines, different program rules and regulations, different state regulations, et cetera. And I think for the more experienced provider that's probably more able to make some of these clinical decisions, or maybe they work under more of a guideline setup and medical direction is super involved, maybe they feel comfortable kind of deviating from this. But this is something that I see more in maybe the younger provider. They're learning mechanical ventilation. It doesn't follow the context of rules, right? And now we're getting into really the different pieces of how we progress the model of skill acquisition, right? And of, novice, advanced, beginner, right? And then there's a big difference between somebody that is just learning. They could have been a very experienced nurse, paramedic, physician, but then they're getting into a different area of that field, right? And now they're in critical care transport just because they might have been, somebody that felt super comfortable running really any call on an ambulance. Now they're taking care of patients with mechanical ventilation. They've got to make these decisions. And if it doesn't follow that guideline path of that protocol bulleted, hey, we're going to do this. We're not going to allow plateau pressures greater than 30. This patient that I kind of highlighted, it doesn't follow those rules. And that's where clinical providers get into trouble. And it's difficult. It's difficult for them because it makes it very difficult. That's why I think you had two other flight services that struggled transitioning the patient over, right? And I'm not faulting them for that. They obviously felt like that was beyond maybe their scope or maybe their guidelines or whatever, or maybe their medical direction made that decision. And I think you said something perfect. You got to have good conversations with the medical direction. You have to have that relationship. If in doubt, always turf that decision at them. But what advice do you have on really, and I talk about this in other podcast of, we have that black or white kind of mentality, and critical care is really 50 shades of gray. You got to be able to kind of work through some of these problems, and some of these problems are not problems that you even maybe suspect that you would ever get into until you see it. So what advice do you have for being fluid in some of these decisions?
Couple things. One, proactive is better. So thinking about these cases, inevitably things will come up where you're not prepared for it, but being proactive in the future. So sitting down and be like, we had this tough case. We should talk to one of our ICU docs and our medical director and people and get them on board. If we have one of these patients, do we want to say that we can continue to go up on the PEEP? Do we want to say that we can titrate the PEEP in this way, that way, or the other way? Or should I just call a medical control and walk through it with one of the medical control physicians or the receiving intensivist? So proactively addressing it. Two, if you're at the bedside and in these situations, these are incredibly complex patients, right? You have patients where you walk in, you see their DKA, they're pretty straightforward, whatever, right? You know exactly what to do. It's pretty simple. It's pretty straightforward. There are complicated patients that have a lot going on with them, but generally if you sit down and think about it and look at their blood gas, you can be like, oh, well, they're ventilating fine, but this is an oxygenation problem and it looks like they have ARDS and this, that, and the other thing. And then you apply the therapy after thinking about it carefully and it works. And there are some patients like this lady that are incredibly complex and there's no clear guideline or book. She may cross over guidelines. And in fact, those guidelines may be contradictory, like the potential obstructive pathology and also ARDS and restrictive pathology from her obesity. So how do you deal with that? Well, I think the answer is, and especially, in conjunction with some help, specifically like medical control, or if not, thinking about it safely and saying, okay, how am I going to suss out which of these two things it is? So on the Hamilton, for example, you could say, all right, well, let me just look at the waveform. Is she fully exhaling? Wait a second. There's no auto peep. She's fully exhaling. The flow waveform is going back to 0 before each breath. This patient really isn't air trapping. Even if she has the diagnosis of COPD, oh, wait a second, she's really not on any meds for it. There's no, she's not seeing a pulmonologist. Maybe the COPD is the lesser part of the problems. Her main issue is oxygenation, and that is from both her restrictive pathology from her obesity and her ARDS. Okay, now we've clarified things by carefully testing the system, giving her a breath, and seeing how her lungs actually respond in real time. And then thinking about, well, if the air trapping and the obstruction is not really the physiological issue here, and it's her obesity and ARDS, well, let's try going up on the PEEP and see what happens. So you test it, go up on the PEEP by 2 or 3 and see how the system responds. So her oxygenation goes up. You're actually ventilating her with, when she's getting breaths in at lower pressures. Your driving pressure is staying the same or coming down even. You've recruited lung and things are looking better. You tested the system and you know that worked. So now, even if you're going up on the PEEP and let's say you get to 14 and, the SATs came from 84 to 88, if you were to call me as the medical director, and even if this is going outside the current guidelines and you're calling me for permission to discuss this case and walk through these, you've given me super helpful information, right? Because you've already tested the system and worked through what it's not. Obstruction and COPD is not the issue. And you're giving me very valuable information to help you work through the problem. Like, I went up on the PEEP and her plateau pressure essentially stayed the same. And she's actually, okay, great. Now we can work through this together, and continue to optimize her by going up on the PEEP. Let's say you're in a place right in the middle of nowhere, there's no medical director available and no one you can talk to. Well, at least you know now that you can test the system carefully, right? It's a pretty safe test. For example, with PEEP, it's not like giving neuromuscular blockade or something that's hard to reverse. And you're seeing that the system responded. So you can go up on the PEEP again, see how it responds. If the driving pressure starts going up, time to stop, right? If her oxygenation gets worse and you've over-distended those lungs at that point, time to stop, go back a little bit. So that's how I would approach the complexity of the situation and encourage crews to think about these problems.
I think you bring up some good points. Obviously, not everybody's using the Hamilton T1. There's other ventilators out there. But if you are, and I think to kind of highlight what you said, a few things that I see when I teach these mechanical ventilation masterclasses is, we really try to teach from 2 pathways, right? Injury versus obstructive approach. And it's very, very easy. We give certain cases to students that they have a history of COPD, but they're there for upper GI bleed that cause respiratory failure and decline. And it's really easy. It's really good to watch. And I've seen this hundreds and hundreds of times. And you get some that clue in on, hey, COPD, even though that's not why they're there. They're there for respiratory failure. This is an injured lung until proven otherwise. They might have elements of the disease process that you have to worry about, but that's important, is why are they there? And I think for this patient that we brought first, she's there initially for COPD, progresses to pneumonia, sepsis, right, and then goes to ARDS. And you brought up utilizing some of your parameters, looking at your waveforms, but the parameters on the vent, and specifically monitoring TAP 3 on the Hamilton, gives you so much information. And I, in the Art of Ventilation course, I talk about this. These parameters should never be a way for you to diagnose a problem. It should be more of a confirmatory tool to strengthen your suspicion, the way I look at it, right? And so you have your RINS, right? It's looking at airway resistance above and beyond what your peak is. Well, for a COPD patient, an asthma patient, obstructive patient, that's probably likely going to be on the high end. And we know predominantly those patients have really good static compliance. But ARDS is just the opposite. They're going to have low insulin resistance. They're going to have low compliance, right? And so I think you can look at those numbers on this patient and say, hey, I might have a little bit more of an elevated resistance than normal just based on her patho. But man, my static compliance is in the toilet. And I have a normal RCX, right? I have a normal exhalation phase, right? So I'm really not dealing with a COPD problem. I'm dealing with true lung injury, ARDS problems. I just need it to generate a higher pressure because of the obesity, maybe the way she was laying, other confounding issues. So you said a few things that were powerful. We talked about plateau pressure and how plateau pressure in that obese patient is not a true reflection of respiratory compliance. And can you maybe expand on intrapulmonary pressures and really using that number instead of plateau pressures or in conjunction with driving pressures to make clinical decisions?
The transpulmonary pressure is the pressure across the lung or the alveolar membranes, if you will, that results in elongation, stretching of those tissues, and the distension of those tissues, which is dangerous or injurious, right, at certain levels of transpulmonary pressure. We have for a long time used plateau pressure as a surrogate for that number, with the understanding that most people don't have a ton, literally a metric ton, like 1,000 pounds, or a lot of soft tissue pressing down on that. And we say, okay, well, the plateau pressure is about as good as we can get. To clarify one thing, there are some institutions that actually use esophageal manometry. So they actually stick a little balloon down into the esophagus and they measure the pressure in between the lungs and the chest, which actually measures the transpulmonary pressure. That is not feasible in our environment. So now we're left with these surrogates like plateau pressure that may not actually represent the transpulmonary pressure in an obese patient, because all of the chest wall, fat, muscle, etc., is pressing down on the lung, down on the chest, down on the lung, which is making that pressure seem higher than it is. That leaves us with a challenge. If we don't have the diagnostic stuff in the pre-hospital environment, like how do we actually know what the transpulmonary pressure is? Really hard to say. And this is why I always recommend people, when you get to these kind of decisions, to calling for help if possible. Is it safe and reasonable to go to a plateau pressure of 35 or higher for some of these patients? Probably. It probably is. And sometimes we will do that in the ICU, but it takes careful consideration and thought. And the answer is we really don't know if that's 100% safe or not. So if that is the difference in the pre-hospital environment between critical hypoxemia and getting them to oxygenate better, personally, I would say I wouldn't recommend that people consider liberalizing that pressure a little bit, accepting a slightly higher plateau pressure to get this person to oxygenate better, understanding that the plateau pressure in this situation, when the person weighs 800, 700 pounds, is probably not truly reflective of their transpulmonary pressure.
This case example, talking to the crew afterwards, I think those were some of the highlights. I think you have to have a great medical director that's willing to be involved, number one, understand this stuff to the point of helping make the decision. But you're never wrong calling medical control and bouncing this stuff off your medical director. And I have to say, I've been really lucky through my career to have really involved medical directors that you have solid relationships with, that you can call and ask these questions.
And I would add kind of to our discussion on the pressure piece, if you have, for example, the Hamilton, right, and you have them in CMV plus S or whatever it is, right, essentially the PRVC, that volume directed, that volume targeted mode. Often you will not get the volumes that you need, and you will run into problems at the bedside because of the alarm pressure limits will cut off the breath. So the person will get very teeny tiny tidal volumes because the Hamilton, as smart as it is, can't look at the patient. That's your job. And it doesn't understand that it's not necessarily fighting against super stiff lungs. It can't see all that other tissue and all the other stuff that it's fighting against to ventilate the patient. In various studies, it will take somewhere between 20, 30, as high as 40 or 45 centimeters of water inspiratory pressure to be able to move all of that belly fat that's pushing up against the diaphragm, chest wall, adipose tissue, and all those other things, and do it safely in order to get the breath in. Which means, and again, please talk about this beforehand with your medical director or discuss with someone on the phone, but it's very reasonable if you guys think through it and it seems safe and appropriate to liberalize that pressure limit to allow the breath to go in and out, understanding that in this circumstance with a super obese or morbidly obese patient, that probably is what you need to safely ventilate that patient.
Whether you're in volume adaptive on the Hamilton or pressure biphasic, the alarm limits will limit your breath. And so it defaults at a alarm limit of 35, meaning the Hamilton will limit the breath 10 below that. So it will never exceed 25. And in this patient, it took a total PIP of 30 or inspiratory pressure of 35 to ventilate and move enough volume based on her resistance. And so that means that, when I was on the phone with medical direction and trying to walk through this, I just told them to crank the alarm limit all the way up. Let's get that out of the problem at this point. And that's what it took. And so their breath was being limited. And I see that all the time. And that's a problem really in the obstructive lung patient, more so in the injury patient, right? I think this is a case that is very different because you have elements of each one. You see that in the obstructive lung patient where you're getting low tidal volumes, and we're, again, we can't think outside the box, and you're thinking, okay, well, I don't want to have a PIP greater than 35. Alarm limits set at 35 or 40. Your PIP is basically limited at 30. Let's say if it was at 40, well, what if they need 55 to overcome the resistance? And so I think that is a huge, it's such a huge thing. You got to take that out of the equation on certain patients.
Yeah, 100%. I think it's very reasonable in these patients, just so you can get the volumes that you need, or temporarily at least to kind of suss things out. I think is absolutely reasonable. I will also add that you will very well see, especially if you're going to pick this patient up at a sending facility. Some of this facilities, I'm sure you guys have been at, the ventilator that the patient is on, oh man, like a Parapack or something, straight out of like the 1990s. That's not necessarily super helpful, but some of the ventilators are quite good. And the corollary to that is if they have them in a volume control setting, don't be surprised if you see the PIP alarm going off on the ventilator and giving you an inspiratory pressure alarm with PIPs in the 40s or 50s, right? That would not be surprising to me if I found a patient that weighed like 600 or 700 pounds laying flat. I would expect that.
We forget the equipment is trying to help us, but it can also limit us. And if we forget that, the last thing you're thinking is the piece of equipment is minimizing or limiting your ability to deliver that breath. And so that's a big piece.
Yeah. So in this, the second case kind of highlights similar issue. This was actually a case that EMS encountered and brought into our emergency department, or emergency department XYZ, we'll call it. And that particular patient was found, he was almost 900 pounds, and had been laying in the same bed for more than a year and a half. The only way that they could get this patient out of the house was to knock down part of the door frame. They rolled him out of the bed that he was in onto another king-size mattress and brought him out like a taco because the stretcher no stretcher that was available could managed this patient's weight, and he was pretty sick. He was in respiratory distress. And so they brought him into the fire department. And once they got him in the taco, he was laying on his belly, which at the time he said he could breathe okay. They put him in the ambulance in this king-size bed taco on his belly and brought him into the emergency department. And everybody in the emergency department was like, what do we do? And the decision was just to leave him on his belly on this king-size mattress, and do everything they could while he was laying prone on this king-size mattress. As it turns out, eventually, he started to have more and more trouble ventilating. His blood gas was getting worse and worse. His CO2 was starting to climb. His pH went from like a compensated 7.29 down to 7.21, and eventually into the like 7.09 realm as his CO2 was climbing into the 90s. And the only option when I came down to admit him was to get him on like a bariatric bed or something, but it was going to take a while for that to happen. So what we did was we ended up putting 2 stretchers together and 2 ED cots together side by side. And we bridged them with those sliding plastic things that we use to slide patients back and forth in the CT scanner. And it took, I think, 12 or 13 of us, to lift this king-size mattress and roll the gentleman from prone to supine. We were able to adjust him so that he was basically head straight up to the ceiling, good sniffing position, and we put him on non-invasive ventilation, which started to help, but they put him on settings that were very low, like 8/14 or 16, which is probably fine for one of us, but not fine for him. And they're like, what should we do? When I said, first, go up on the PEEP to at least 14 or 16. And then we're going to titrate his inspiratory pressures up until he is comfortable and ventilating appropriately. So we just worked with him, going up on the pressures, telling him what I was doing. And eventually, I think we got to an inspiratory pressure, the IPAP was almost 40, I want to say. It was like 38 or 40, and the EPAP was 14 or 16, which was actually, I thought we were going to have to go higher, because that's only an inspiratory pressure, like a delta P of like 15 or 16, right? But that's what it took. It was really more PEEP and opening up those alveoli that can now ventilate, sitting him up, and then going up on the inspiratory pressure, so that we could actually ventilate him. And you watched him breathe more comfortably. His respiratory rate came down. He was able to talk to us in like 4 or 5 sentence or 4 or 5 word sentences, and his blood gas improved, and we admitted him up to the ICU. He ended up not getting intubated. Everybody was very concerned about going up on these pressures. And as soon as I reassured them, we talked through like the physiology and carefully stair-stepped those pressures up, everything got better, and he did just fine. And that was very reasonable. The moral of the story there is going in hand with the story that you had. That was problems oxygenating. This was problems ventilating. And we were basically able to do that just by optimizing his FRC, opening up his lungs with that EPAP or the PEEP, right? And then carefully and thoughtfully going up on the inspiratory pressures to support his ventilation. Even though those numbers looked kind of scary, based on his physiology, that's what he needed.
This is another example of this doesn't follow the standard rules, right? We've talked about this so many times that, we try not to keep IPAPs exceed 20, right? But again, based on the previous case and the weight of the chest, the weight of all the adipose tissue, going up to 15 or 16 of an EPAP is a huge number. But you had to do that, right? And so I love the kind of the foresight of looking at that and going, man, we're going to have to really, and a total IPAP of 40 is huge, but this is not the standard patient. How many kilos approximately are we talking about?
868 pounds, something like that. I forget whatever that comes out to in kilos.
Yeah.
Hundreds of kilos. Yeah. Big, right? I think the other advantage, and especially when it comes to some of these things, the advantage that we have in critical care transport is the nursing ratio, if you will, is always going to be like 2 to 1. So there's always going to be 2 transport professionals with this person. And these patients it is not someone who I would feel comfortable with just like setting these numbers and telling the respiratory therapist and walking away and getting lunch, right? You can't do that. And one of the advantages we have in transport is you're constantly with this person. So you're constantly talking to them and working with them and explaining to them what you're doing and try and verbal judo them into being comfortable with the settings and telling people why. And with every change, you're watching them. You're watching their physiology. You're watching their respiratory rate. You're watching their work of breathing. You're getting feedback from the ventilator. And these close cycles of watching how the patient responds is probably a pretty safe way to do that, in my opinion.
No, I love that. Well, Mike, is there any other areas you want to hit on? I mean, I think that the big focal point is that none of these patients that we talked about today, either of them are the standard. They definitely fall outside the standard. There's definitely some curveballs, but I think we hit on, the big important piece is understanding the pressures that you see may not really reflect the standard that you see with all other patients. Is there anything that you kind of want to sum up before we end the podcast?
I think if I was to summarize it, I would harp on three things. There's really three things I want people to take home and away from this. One is, not surprisingly, these patients are at risk of all-cause mortality. Like their risk is higher overall. They will be sicker. They present to the emergency department more often. They die more often as a result of just from their obesity plus all their other medical problems. So be aware, because we're going to run into them. Two is just understand the baseline physiological changes that predispose these patients to respiratory issues at baseline, right? All of that adipose tissue in guts, pushing up on their diaphragm, pushing down on their chest, limiting their functional residual capacity. So at rest, they have a lot of shunt, they have tiny little aerated lungs, and it's hard for them to take big breaths, right? Their forced vital capacity. It's hard for them to take big breaths. Because of that, lesson number three, the take-home point number three, is that when we're supporting these patients through the course of their respiratory disease with either non-invasive ventilation or invasive mechanical ventilation, they will likely need higher pressures to maintain functional residual capacity, open up those lungs, and oxygenate them well, because of all the tissue pressing down on their chest and up on their diaphragm. And they will likely need higher pressures to ventilate them. And even though these pressures are higher than normal, they are probably safe and reasonable based on their underlying problems, specifically their obesity.
Well said. Well, guys, as always, if you have any questions, don't hesitate to reach out. Mike's email is michael.lauria@flightbridgeed.com. Obviously, eric.bauer@flightbridgeed.com. We will definitely respond to you immediately. There will be references to this podcast in the show notes, as always. And if you have any ideas for new podcasts, any case studies, anything like that, please reach out to us, and we will talk to you soon.
This has been a production of the Flight Bridge Ed Podcast, leading the way in pre-hospital critical care and emergency medicine education.